guys, welcome back to my channel. So firstly I will give you guys a short review of this video. Great. Syphilis is basically caused by a bacterium Treponema pallidum. Sexual contact is the main cause of this disease. Along with reproductive organs, nervous system, joints of skeleton, eyes, hearts and skin are affected. On the skin, small spot might be appeared. So this is the video. This is all about the video. Introduction. Syphilis is caused by infectious treponematosis caused by Treponema pallidum, transmitted usually by sexual intercourse. Discovered by Schwarden and Hoffman in 1905, affects most of the organs, marked by florid manifestations on the one hand and years of asymptomatic latency on the other hand. Affects both men and women in age group of 20 to 40. This is a microscopic view of dangerous arbitrary pallidum named as Treponema pallidum. Structure and physiology of treponemes. Motile spiral-shaped gram-negative bacteria, size approximately 10 to 14 μm in length and 0.1 to 0.2 μm in diameter, 10 regular spirals at intervals of about 1 micrometer. Outer membrane of T. pallidum differs from most gram-negative bacteria in major aspects. Lacks lipopolysaccharides, has dearth of integral membrane proteins, has less cytoplasm and has 9 cytoplasmic fibrils. Treponema pallidum, stealth pathogen, antigenic inertness. Motility. T. pallidum is actively motile, moving with a corkscrew motion with bending and flexing, but with little translational movement. Chemotaxis. Chemotaxis machinery is thought to assist T. pallidum as it navigates throughout the body during dissemination. Recent microarray studies indicate that a number of chemotaxis genes are upregulated during early active syphilis infection. There are two strains, Nichols and Reiter strain. Metabolism and survival in vitro. Lacks genes for Krebs cycle, heme proteins involved in electron transport. Heme means to hemoglobin. Okay. To synthesize most amino acid, purines, pyrimidines and lipids, this suggests that T. pallidum is able to generate only 2 molecules of ATP per glucose molecule through glycolysis. Accounting for its significantly lower growth rate, generation time for 30 to 33 hours, survives better in microaerophilic rather than anaerobic conditions. So far, it had been cultured in artificial media. As you can see, the natural history of untreated syphilis, it can be explained into steps. So first step is inoculation, which leads to 14 to 21 days of incubation, mostly range up to 9 to 90 days. And the second step is primary syphilis, which is also called hermatogenous dissemination, which takes up to 2 to 12 weeks after appearance of Chandra. And the third step is secondary syphilis, which takes up to 3 to 8 weeks. In this condition, lesions disappear spontaneously. And the fourth step is latent syphilis, which is actually depends upon secondary syphilis, takes up to 25% of patients relapse within the first 1 to 2 years, or the latent syphilis takes up to 2 to 20 years, which leads to no recurrence, which might be curable, or tertiary syphilis, which definitely leads to an end. This is how syphilis reacts step by step. Pathogenesis, mode of transmission, sexual intercourse, blood transfusion, contaminated needles, vertical transfusion or transmission to hospital personnel by indiscriminate handling of infected lesions, attachment, invasion and dissemination, innate host response TLR2, acquired immunity, clinical manifestations caused by inflammatory and immune responses rather than by any direct cytotoxic effect of T. pallidum, bacterial clearance by phagocytosis of treponemes and macrophages, predominant cytokine Th1 and predominant mediator in INFY, antibodies in syphilis, invasion of host immunity and establishment of latent infection, protective and long-lasting. Classification of syphilis. Clinical course of acquired syphilis is divided into early and late syphilis. Early duration of its first years include primary and secondary stage and early latent syphilis. Late after 1 year include late latent and tertiary syphilis. Congenital syphilis. Cooley's law proposed in 1837. Syphilitic infants could transmit the disease to previously healthy wet nurses but never to their own mother. Kazovit's law, proposed in 1876, untreated syphilitic mother tends to improve on her past Primary syphilis starts as painless erythematous indurated papule ulcer, usually single painless, clean, well-defined, non-tender, and markedly indurated. Site genital, perineal, and anal area. However, any part of the body may be affected. Syphilis deambly, when primary channery may be overlooked or concealed. Invasion of ulcer with Vincent organism may result in gangrenous changes, heal spontaneously, leaving behind tissue paper scar. Lymphadenopathy in lingual lymph node invariably involve multiple non-tender discrete debris and usually bilateral, regardless of stage of disease and location of lesion. Histopathologic hallmarks of syphilis include endarteritis, which in some instances may be obliterative in nature, and a plasma cell-rich infiltrate. Secondary syphilis, 2 to 12 weeks of development of primary syphilis. PT manifest with symptoms of secondary syphilis characterized by low-grade fever, malaise, sore throat, headache, adenopathy, and cutaneous or mucosal rash. Manifest as evanescent copper-colored muscular rash. A few days later, symmetric papular eruption appears involving entire trunk and the extremities, palm and soles. Papules reddish brown, scaly, discrete, 0.5 to 2 cm in diameter, variates. Postular combination of these lichenoids and acne-form nodular, craniate, corimbose, annular. 25% of PTS have abnormal CSF. Latency. Definition: persons with historical or serological evidence of syphilis who have never received treatment for this disease and who have no clinical manifestations, symptoms or signs require exam of CSF to rule out asymptomatic neurosyphilis. In Oslo study of untreated syphilis, secondary relapses occurred in 25% of patients whose infection had become latent, with most relapses occurring in the first year. US Public Health Service therefore defines early potentially infectious latency 1 year from onset of infection. Tertiary syphilis. Morbidity and mortality of syphilis in adults in past years were due to late manifestation of illness. There may be an interval of 1 to 20 years from acute infection to clinical onset of late or tertiary stages of disease. Tertiary syphilis conveniently divided into 3 main groups: late beginning syphilis, cardiovascular syphilis, and neurosyphilis. Beginning tertiary syphilis, characterized by gamma and appear 3 to 10 years after infection. Proliferative granulomatous inflammatory process causing destructive of affected tissues. Most lesions occur in skin and bones with lesser frequency in mucosa and of viscera, muscles, and ocular structures. Theory. Best evidence in support of hypersensitivity was provided by Mackinson et al., who inoculated volunteers in Sing Sing prison with the Nichols strain of T. pallidum. Gummas develop only in persons with a history of previous syphilis. They concluded that superinfection in sensitized patient may explain gumma formation. Clinical manifestations. Skin. 2 forms may appear: nodular and nodular solitary lesions. Nodular and nodular lesions, deep indurated nodule, reddish brown in color that varies in size. Multiple nodules distributed in axiform pattern, side, face, scapular, interscapular areas or extremites. May remain for weeks or months and may heal without breaking down but show scarring. If nodular lesions break down to nodular form, they heal, leaving atrophic non-contractile scar. The solitary gumma, subcutaneous process that involves the skin secondarily, side, thighs, buttocks, shoulders, forehead, and scalp. As it becomes necrotic, it has characteristics of cold abscess. These lesions resolve promptly with effect. Skeleton, periostitis, gumaceous ostitis, and sclerotic ostitis. CFS pain, especially nocturnal tenderness, swelling, bony tumor, stiffness, and limited motion. Upper respiratory tract, mouth and tongue, gumaceous ostitis of the nasal bone, hard palate, and nasal septum. Perigonditis. Digestive system can involve any part. Gumma of the liver was the most common. Myocardium gummas, especially of the left ventricle and commonly asymptomatic, have been reported. Cardiovascular syphilis clinically manifests after latent period of 15 to 30 years. Pathology: spirochetes appear to have predilection of vasa vasorum of aorta, particularly the proximal aorta, produce transmural inflammatory lesions and arteritis of these vessels. Obliteration of lumen of vasa vasorum, the aortic media develops patchy necrosis with subsequent focal scarring. Aortic aneurysm (MC) manifestation virtually involve ascending thoracic aorta. Symplectic aneurysm do not dissect, probably because of the medial scarring and wall thickening. Symptom develop when aneurysm encroaches on surrounding structures or ruptures. Radiograph may be an or show a mediastinal mass and typical eggshell calcification outlining aneurysm. Coronary artery disease: only the ostia or most proximal few mm of coronary arteries are affected, may lead to IHT including angina pectoris or sudden death. Aortic regurgitation: pure AR without stenosis formerly was common cardiovascular manifestation occurring in roughly 30%. Neurosyphilis: abnormalities in CSF have been noted in 13% of the PTS with untreated primary syphilis after initial invasion of CNS during early syphilis and treated infection, may resolve spontaneously, persist as asymptomatic syphilitic meninginitis, progress to symptomatic acute syphilitic meninginitis. Progression of early asymptomatic or symptomatic meningeal infection may lead to meningovascular syphilis, usually 5 to 12 years after primary infection, or parenchymatous forms of neurosyphilis such as stapes or paresis, usually 18 to 25 years. Lab diagnosis of syphilis. Tests are divided into 4 categories. Direct microscopic exam used when lesions are present. Non-treponemal test used for screening. Treponemal tests are confirmatory direct antigen detection tests used in research settings and as gold standards for test evaluation. Treatment: primary and secondary syphilis are easy to treat with a penicillin injection, widely used antibiotic, and it's usually effective in syphilis. People who are allergic to penicillin will likely be treated with a different antibiotic such as doxycycline, azithromycin, ceftriaxone, tetracycline. This is the gram-negative test of syphilis (VDRL). Ceftriaxone tetracycline. This is the gram-negative test of syphilis (VDRL).